join me. Right. Okay. So what we are going to hopefully achieve over the next sort of 5 weeks is that I'm going to take you through the MCQ components of all the sort of sections in medicine, right? And we will do a sort of a rapid revision of all the important topics in medicine. There are, in the question papers that I send, there are also SCQs. I'm not sure whether I'll have time to discuss them in detail, but please make sure that you write an answer to those SCQs as well. And if we have time, hopefully we should be able to do some level of discussion on selected SCQs somewhere after we finish the MCQs. And even neglect karanna epa, because actually last time, looking back at the results, some of the people who failed had done really badly on the SCQs, right? So don't forget that there is an SCQ component. It doesn't count your common MCQ, but it is still an important component. So make sure that you write answer. Just don't do that. Just write the answers, time the answers and write. Okay. Right. So today we're going to start off with heart failure. I think there are about 6 or 7 MCQs in that paper. And most of these concepts you've talked about during your professorial appointments. So this will just be a rapid revision. And it will be a good idea sort of keep up with what we are doing, revise kalla, maybe attempt these questions without looking at your books, and that will be a nice revision for you for the exam. Okay. Right. Now, as you know, there are several clinical entities of heart failure, right? And one of these entities is the syndrome of chronic heart failure, right? So this is syndrome of chronic heart failure. And essentially, what you mean by heart failure is there is a collection of symptoms and signs which you have discussed in detail during the clinical appointments. And here there is either a abnormality in structure of the heart or a functional problem within the heart, right? So that is what happens in heart failure, right? Now, the first MCQ, true-false MCQ, is focusing on the etiology of heart failure. Now, as you know, chronic heart failure, you divide the causes into 2 big groups. Right? On one hand, you have heart failure with reduced ejection fraction. On the other hand, you have heart failure with preserved ejection fraction. And if you remember what I taught you during your appointments, in heart failure with reduced ejection fraction, the main problem is it is a systolic failure of the heart, right? It cannot maintain an ejection fraction. It is a systolic failure of the heart. In heart failure with preserved ejection fraction, the ejection fraction is normal, but the heart, there is a problem in the diastolic function of the heart or the filling of the heart. That is where the problem lies. So this is your 2 broad groups. Right. And the etiologies can differ whether it's a heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. Right. Now let's do this one. True or false regarding heart failure, ischemic heart disease accounts for most cases. So that is right. So patients with heart failure, ischemic heart disease is the commonest etiology. Hypertension is a very close second, right? And especially in Sri Lanka, it is mostly ischemic heart disease that we see as presenting with heart failure. So that is correct. Now, if you take heart failure with preserved ejection fraction, I told you there is a problem in filling of the heart. So there is a diastolic problem or a diastolic dysfunction. Now, in elderly, we see quite a lot of heart failure with preserved ejection fraction. It is very common. The reason is, as you get older and older, your ventricles become more stiff, right? Your ventricles become more stiff, right? And also, patients develop hypertension. So adults, and when they get older, they develop hypertension. Hypertension again causes left ventricular hypertrophy and ventricular stiffness, right? So that is another contributory cause. So yes, heart failure with preserved ejection fraction, the incidence increases with age, And this is because the ventricles are becoming more and more stiff as you go on. The ventricles are hypertrophying, and there again, when the ventricle is hypertrophic, the stiffness of the ventricle increases. So they have problems in filling. The diastolic dysfunction is apparent, or there is diastolic dysfunction. Right. So that is true. Of course, heart failure with reduced ejection fraction is also common in elderly because as you age, they get more ischemic heart disease, right? So, but clearly we see an increase in heart failure with preserved ejection fraction in the elderly. Right. Now, the statement number 3 is can occur as an adverse effect of doxorubicin therapy. So doxorubicin is a chemotherapy agent, and this is a big thing now. Right, this is a big thing now. We recognize lots of chemotherapeutic agents can cause cardiac toxicity, and they present with dilated cardiomyopathy and heart failure. And doxorubicin is a very famous chemotherapy drug that has cardiac toxicity. And actually, there is a whole branch of cardiology which deals with cardiological issues in patients with cancer. Right, whole branch of cardiology and cardiology specialists who only do cardiology in patients with cancer. Right, so doxorubicin leads to dilated cardiomyopathy and heart failure. Right. Statement number 4 we have already discussed. Right, so in heart failure with preserved ejection fraction, the main issue is there is ventricular stiffness. Right. So the ventricles cannot fill up, right? The ventricles are very stiff, they cannot fill up. And if you measure the intraventricular pressure, the pressure inside the ventricle is elevated, right? Because it's stiff, right? When the blood fills in, the ventricle can't get bigger, so the pressure inside increases, right? So that is what happens. Right. And the final one is activation of the renin-angiotensin-aldosterone axis counteracts the pathophysiological process. Then make a balluot. Now this again I have taught you, right? In a patient with heart failure, as you know, as a compensatory mechanism, right? As a compensatory mechanism, you get activation of the renin-angiotensin-aldosterone axis. The idea is of this axis is try to preserve organ perfusion. Right? It is trying to preserve organ perfusion. It is trying to retain salt and water, right? Increase the blood pressure, right? And all of this. But as you know, the salt and water retention, the vasoconstriction that you see in a long-term scenario with time is harmful, right? Especially because this axis causes salt water retention, it increases the stress on the heart. And also, this renin-angiotensin-aldosterone axis can give rise to damage to cardiac muscle, right? So cardiac myocyte death can occur when this axis is activated, Hi. So any questions about this particular MCQ? So it deals with mainly the etiology and the pathophysiology. Now remember that it is very easy for us to set a question about the pathophysiology of heart failure. So make sure that you are very clear about writing an answer to that, because that is something that can come in the SCQ. Yes, Tisura, you have a question?
Yes, sir. The second stem cell heart failure with preserved ejection fraction is common compared to reduced ejection fraction.
No, this is so. This is what it's saying is in the elderly population compared to the younger population, you see more heart failure with preserved ejection fraction. Yeah.
Right. Got it. Thank you.
Right. Now the next slides, I will send all of these slides to you. Maybe from next time I'll put it on just before the session. So this is just as a summary. Was there any other question that you wanted to ask?
Excuse me, sir. The last
Actually,
one, is it counteracts the pathophysiology?
So here, So counteract it works against the pathophysiological process. So it's actually this is the problem, right? So it is not a counteraction. It is the problem. It is the primary pathophysiological process. The English is a bit vague on that, but this I think I took from one of your past papers. I can't remember now, right? What you have to understand is the renin-angiotensin aldosterone axis is the problem. That is the problem, right? There is another system that counteracts this process, which is the BNP system, right? Remember that? So that counteracts this system.
Thank you.
Right. Now, this, and again, I will share this with you and also another note ekak wage, so that you have something to refer. Right? So this gives you a sort of a etiologies of heart failure with reduced ejection fraction and preserved ejection fraction. And again, observe that when you have heart failure with preserved ejection fraction, all of these things, say like hypertension, hypertrophy of the heart, myocardial fibrosis, you can now observe that all of this causes a problem in the stretch, ventricular stretch. It's very stiff. The ventricle is very stiff, right? That is the problem. Okay, right. So let's move on to the question number 2, right? So this is a sort of a clinical plus investigation related MCQ, right? Now, when we talk about symptoms and signs of heart failure, this is should be very familiar at this stage with or less than 2 months to go to the exam. Neither. So when you have heart failure, you get symptoms and signs because of right heart failure, right? And also symptoms and signs because of left heart failure. Because of left heart failure, the main consequence is congestion, right? Pulmonary congestion, right? Because when the left heart fails, blood accumulates on the left heart. That increases the pressure in the left atrium, pulmonary veins, causing pulmonary edema, right? So there is a back pressure because of the left ventricular failure. There is a back pressure that causes pulmonary edema. There is accumulation of blood on the left side, and that leads to pulmonary edema because of pulmonary congestion, right? Because of the right heart failure, there is a lot of congestion in the tissues, right? There is a lot of congestion within the tissues itself, right? Because the right heart receives blood from the superior and inferior vena cava. So there is tissue congestion. So you get edema, right? Liver congestion, elevated JVP, right? All of this. And the MCQ, the first statement, looks at heart failure can lead to hepatic dysfunction. And that is true because, and that is a consequence of right heart failure. So that occurs quite a lot in patients with right heart failure, right? Where they have hepatic congestion. The hepatic congestion with time and lead to cirrhosis as well, right? Cardiac cirrhosis. We call this cardiac cirrhosis. The liver congestion can lead to cirrhosis of the liver, right? So that is the problem. So can lead to hepatic dysfunction is true. Right. Now, the next statement, you have to be very careful. Pulsus paradoxus is diagnostic of left ventricular failure. Now, we'll talk about pulsus paradoxus on Thursday, right? And there are several conditions that give rise to pulsus paradoxus, right? And I'm just going to show you a small picture of this, right? So this is what pulses paradoxus looks like, right? And you can see that there is an alternating arterial pressure in expiration and inspiration. I will explain the pathophysiology of this on Thursday when we do pericardial disease, because that's where it's most relevant, right? That's where it's most relevant. Pulses alternance is, right here, a beat-to-beat variation of the pulse volume and the blood pressure. So if you feel the pulse, from each beat, you can feel the difference, right? And there's a high volume beat, low volume beat, right? And you can, using a sphygmomanometer, you can also listen to the difference in the sounds as well, right? Because there's a variation in the pulse that you feel from beat to beat. And this is considered to be a unique feature of advanced left ventricular failure, right? This is considered to be a unique feature of advanced left ventricular failure, right? Pulses alternance, where you have beat-to-beat variation of the pulse volume, and you can also do a blood pressure measurement and check the difference. There is a way of doing it, which I don't think you need to worry about at the moment. Right? There is a technique in how you use the blood pressure cuff to measure, to look for pulses alternance. So the important thing to remember is pulses paradoxus is not pathognomonic of heart failure. It is seen mostly in pericardial diseases. We'll talk about that on Thursday. But pulses alternance is supposed to be quite unique to advanced left ventricular failure. In advanced left ventricular failure, right? So that is that. So pulses paradoxus kenika varadi, it is pulses alternance that we are talking about, right? And it is virtually diagnostic. Yes, it is virtually diagnostic of advanced left ventricular failure. Right. So that is that. All right. Then looking at investigations, I told you that the echocardiogram is a very important investigation in heart failure. Matakaini. And the echocardiogram allows us to say, okay, is this heart failure with preserved ejection fraction, or is this heart failure with reduced ejection fraction? And it's a beautiful investigation to differentiate the two. But of course, you do other investigations, and one of them is the chest X-ray. Right. I hope you remember this. Right. So, right. Now think, what are the chest X-ray changes you see in heart failure? Right. Cardiomegaly. Matakaini.
Hello, sir.
Lamai Henada, sorry, this damn thing got disconnected.
Oh, sir, hello.
Hi. Okay, I don't know why. Hi. Okay, so let me share this again. Right. Hi. So I was talking about the chest X-ray changes in heart failure, and I was talking about upper lobe diversion, right? Cardiomegaly, then prominence of vascular markings around the hilum, right? And also you see these horizontal lines, which we call curly B lines, right? So these horizontal lines here are curly B lines. So you can see this here. I will outline it for you. So this is a nice example of a curly B line, right? So these are horizontal lines which probably represent fluid in these interstitial, interstitial fluid in the fissures of the lung. So there are many fissures that separate the segmental lobes and the main lobes. So these are probably fluid in those fissures, right? So that is a curly B line. And also another very common feature is a pleural effusion, as you can see here, right? So these are pleural effusions. Right. So chest X-ray changes, very important for you to know, right? We can ask you to describe these in an SCQ as well. So that is what you find. So curly B lines are seen on the chest X-ray is true. Right. Now remember, I told you in your appointment that in order to diagnose heart failure, right? In order to diagnose heart failure, what do you need, right? In order to diagnose heart failure, you need a supportive clinical history and examination. You need an echocardiogram, and you, if available, a BNP, right? Remember BNP, we talked about BNP, right? But I told you that in Sri Lanka, we don't commonly do the BNP because we don't have access to it, right? Or limited access in some hospitals only. Now, BNP is triggered off by myocardial stretch, right? BNP is triggered off by myocardial. The main triggering event is myocardial stretch. And the name suggests that BNP, natriuretic peptide, that is what you mean. So what it does is, it has a physiological effect. It causes salt and water retention, salt and water retention. And Panchali, we are talking about, this is the mechanism that counteracts the renin-angiotensin mechanism. Causes natriuresis, that is sodium excretion, and diuresis. So it is a good thing. BNP is a good thing, right? Now we use BNP, elevated BNP, as a marker for diagnosis as well. Apart from this being a nice physiological thing, which helps to counteract the renin-angiotensin mechanism, we can measure this NT-proBNP and the proBNP, right? So NT-proBNP is an inactive molecule, right, which we can measure. We can also measure the proBNP. So important, remember, proBNP and NT-proBNP are cardiac biomarkers of heart failure. These are biomarkers of heart failure. Number one, they are useful in diagnosis, right? So some of the diagnostic criteria out there, clinical features, echo and NT-proBNP or proBNP levels, right? Even though we don't do it in Sri Lanka. Also, another important fact to remember is that the higher the NT-proBNP, that gives you a prognosis benefit, right? So the worse the heart failure, the more the NT-proBNP, right? Because it is sort of trying very hard to counteract this renin-angiotensin mechanism, right? So higher the NT-proBNP, the more severe the heart failure and the poorer the prognosis, right? So NT-proBNP has a prognostic value. That is true, right? The last one in this MCQ is elevated troponin invariably. The word invariably means for sure, right? Or it is diagnostic. Invariable, right? So invariably කියන වචනේ right? So what you mean by invariably is that you have to, it is very strongly related in අනිවාර්යෙන් කියන එක. Now, elevated troponin invariably, so both Rehani, NT-proBNP. So BNP we don't usually measure because it's difficult to measure. So NT-proBNP, pro-BNP, everything has a prognostic value. If you are measuring the BNP, again it has a prognostic value, but we don't measure it because of technical reasons, right? Measure karanda bahe. Okay. So elevated troponin invariably indicates myocardial ischemia කියන එක වැරදි because even this myocardial stretch and strain can also elevate the troponin, right? So it will be very, very careful when you're interpreting troponin in patients with advanced heart failure, right? So that is the problem. So elevated troponin can occur even due to the sort of strain on the myocardium as well, right? So you have to be very, very careful when you are interpreting the troponin, elevated troponin in heart failure, right? In heart failure. Right. So this MCQ, question number 2, focuses a lot on the sort of investigations and clinical manifestations. Right. Any questions from this one? So this is just a figure showing the various clinical features of left heart failure, right heart failure. And the classification left heart failure, right heart failure is mostly used for explanation of clinical features, right? It's not very much used in clinical practice, I would say. Yeah?
Excuse me, sir.
Oh.
Sir, in acute left ventricular heart failure,
yeah.
After we stabilize the patient, if we do a echocardiogram,
yeah.
is it going to show heart failure, reduced ejection fraction, or can it be normal also?
It can be normal. It depends on what the cause is, right? Acute heart failure depends on what the cause is. What is it? So, remember, acute heart failure can sometimes be due to just a lot of fluid as well, right? So, just a lot of fluid where the heart can't cope. Or acute heart failure might be secondary to something like thyrotoxicosis. Ne? So, it all depends on what the cause is, right? But if it is a obviously acute MI causing acute heart failure, you will see a reduced ejection fraction for sure. Yeah.
Okay, sir. Thank you very much.
Right. Then Shamalka has asked, troponin is specific to heart, but troponin is specific to heart muscle. But the problem is that it doesn't always indicate ischemia of the heart muscle. Even in a stress to the heart, it can go up. Just a stretch or stress in heart failure. Right. Okay. So question number 3 and question number 4 and also some of the best response MCQs are also focusing on management. Right. Now, I would have told you during your appointments that for management, we classify heart failure into 4 stages. So there are heart failure, we classify patients into 4 stages. Right. And I told you that stage A, right? Stage A heart failure is the patient has risk factors for heart failure. Right? Risk factors, you know. They don't have any symptoms or signs. And their hearts are structurally normal. Heart structure is normal. Stage B, still they don't have symptoms or signs. But they have structural changes in the heart, right? Maybe a bit of cardiac dilatation, right? Some structural changes in the heart. But they still have not developed any symptoms or signs. They might have some asymptomatic valvular disease, පොඩ්ඩක් LVH එකක් තියෙන්න පුළුවන්. Some sort of structural change is there. But they don't have any symptoms or signs. Then stage C is where, stage C is where you get the symptoms and signs. Right? That is where most of your patients that come to your ward will be in stage C. Right? Stage C. Then stage D is essentially an extension of stage C, because in stage D the patients are very symptomatic. They don't respond to first-line therapies, and they have quite advanced disease, right? So quite advanced disease. Right. So this is your stage classification. So this is very important for the management of heart failure, stage A, B, C, D. Right. Can you hear me?
Yes, sir.
Another.
Oh, sir, hello.
Hello.
Hello, sir, hello.
ඇහෙනවද ළමයි?
Hello, sir.
හරි හරි. සෝරි අනේ මේ ඉන්ටර්නෙට් එක පොඩ්ඩක් කචල්. මට හිතෙන්නේ අපිට මේ ඊට පස්සේ රැට කරන්න වෙන පාටක් තමයි පෙන්නුම් කරන්නේ. මේක මේ දවල්ට මම හිතන්නේ මේ මිනිස්සු ගොඩක් පාවිච්චි කරන නිසා බලමු කරගෙන යන්න පුළුවන් තරමක්. හරි. මේ Wi-Fi ගොඩක් පාවිච්චි කරන හින්දාද දන්නේ මේ වෙලාවට. හරි. Okay. ඇහෙනව නේද දැන් ආයි?
Oh, sir, hello.
Right. That's good. Right. So, okay. So what I was talking about is most of your evidence-based therapeutics, right, is for heart failure with reduced ejection fraction. Almost 95% of proven evidence-based therapies are for heart failure with reduced ejection fraction. Habay, last year, there was some early evidence that SGLT2 inhibitors, right, which are the newest class of drugs for heart failure, have some degree of mortality benefit in heart failure with preserved ejection fraction. And that was probably the very first time that this was shown. So this is a relatively new finding, but it can appear in your MCQ paper, right, because you're supposed to be up to date. Man kiwa goda groups වලට කිව්වා ඕක ගැන. හරි. So heart failure with preserved ejection fraction, currently the only drug that has shown some indication of a mortality benefit is SGLT2 inhibitors, right? That is what came out last year. Hari. None of the other drugs have shown any mortality benefit, right? It's just the SGLT2 inhibitors. But heart failure with reduced ejection fraction, there are lots of medications, right? Several drug types which have a mortality benefit. Right. Right. True or false regarding the management of heart failure? Furosemide has extensive evidence-based survival data. I think I told almost every group. It is absolute common sense that if you don't get furosemide to somebody, they die. It's absolute common sense. If you don't give furosemide to somebody, they die. There's no doubt about that. But because it is unethical to do a trial by not giving furosemide to a group, we don't have any evidence that it has a mortality benefit. So if somebody asks you in the exam, does furosemide have an evidence-based survival benefit? The answer is no. Right? There are maybe one or two very small trials, old ones, but that doesn't have enough weight. But it is common sense that if you don't give furosemide to a patient with heart failure, they will die. There is no doubt about it. But because of a ethical and technical issue of conducting trials, furosemide has not been proven to have a mortality benefit. Harida? Okay. Right. So that is statement number one. Right. Now, again, this, I'm not sure I told everybody because this changed somewhere in the middle of 2022. The current guidelines for heart failure changed. So you have to know what the latest ones are. Based on current recommendations by the European Society of Cardiology, for heart failure with reduced ejection fraction, they recommend 5 first-line medications now. 5 first-line medications. So what are these first-line medications? ACE inhibitors or ARNI. ARNI කියන්නේ angiotensin receptor blocker plus neprilysin inhibitor. Now remember we are talking about this BNP story, right? So what a neprilysin inhibitor is, it increases the BNP, right? The neprilysin inhibitor increases the BNP levels. So that is what so ARNI has a dual action. It blocks the angiotensin 2 receptor. It also enhances the BNP pathway. So it has a dual effect, right? So first line drugs, either your classical ACE inhibitors or ARNIs, angiotensin receptor blocker, neprilysin inhibitor, right? Neprilysin inhibitor is added on to the effect of the angiotensin 2 receptor blocker, right? So that is first line. Second drug is beta blocker. MRA stands for mineralocorticoid receptor antagonist. The one we have in Sri Lanka is spironolactone, right? So eplerenone කියලා එකක් තියෙන එක ලංකාවේ නැහැ. We use spironolactone. So MRA. Then dapagliflozin or empagliflozin are these SGLT2 inhibitors that have proven benefit in heart failure, right? And these are the drugs that also have proven benefit in heart failure, preserved ejection fraction. And finally, loop diuretic. So now all these drugs are considered first line drugs, right? Now immediately we'll have 2 questions. Question number 1 that you will have is, spironolactone is only a second line drug. If the ejection fraction is less than 35 katandaryak, some people will remember. That is no longer recommended. Currently, it is now elevated into a first line class, right? So those days, before this revision of the guidelines, they said that, okay, spironolactone should only be introduced if you're on other first line medication and the ejection fraction remains below 35%. But that is no longer true. Now it is a first line drug, right? That is question number. Question number 2 is, where is the angiotensin 2 receptor blocker? So angiotensin only. So we know that it is not probably as effective as the ACE inhibitor, right? But if they are intolerant to ACE inhibitors, you can consider an angiotensin receptor blocker. Sorry, if they are intolerant. But it is not preferred. An ACE inhibitor is preferred or ARNI is preferred. But in Lankave ARNI nehani, right? So if they don't tolerate an ACE inhibitor, we have to try an angiotensin receptor blocker. It probably doesn't have the same benefit as an ACE inhibitor or an ARNI, right? So that is the second question that you will have. Right. Then, of course, if they don't respond to these, so the European Society of Cardiology, these are your first line medications, right? And you can give all of these first line medications if you like, right? And some people do that because they say, okay, many drugs, you are sort of giving small doses of each, so it might balance out the side effects, right? But anyway, you have a choice of your first line medications here, right? And then comes the second line options, right? Then comes second line options. There are certain pharmacological options as well, but currently there is a lot of push towards using devices as second line therapies, right? Especially if they meet these criteria, right? Nobody is going to ask these from you, but these are your specific criteria for devices. Devices, CRT, cardiac resynchronization therapy, which can be combined with ICD, right? If they have evidence of ventricular arrhythmias, right? Nobody is going to ask those things, but they are recommended, these devices are recommended if you have sinus rhythm and ejection fraction less than 35%, and there is an ECG criteria of a QRS more than 130 milliseconds, right? And that is when you put the CRT device, right? Cardiac resynchronization therapy, right? And then of course you have this other ICDs which can be added on to that device. Not important for you to know. Alright, so let's go back to the MCQ now. Sorry. So first statement, furosemide is an extensive evidence-based survival benefit. කියන එක වැරදි. Angiotensin 2 receptor blocker candesartan is right, and they don't tolerate ACE inhibitors, right? So second statement, sorry, make unstable internet connection killer. I disconnected then, but we will do. I think the problem is it's too early in the morning for this Wi-Fi network, probably. Hari. So yes, Hari. Now,
sir, could you repeat the second one? So we didn't hear you.
Yeah. So second one, angiotensin receptor blockers are not preferred as first line therapy. You have to try an ACE inhibitor, right? So that is what I was saying. Right. Right. We'll come to ivabradine, etc., in a minute, Lidangi. Yeah. Okay. So ACE inhibitors have a role in the management of asymptomatic heart failure. Now, remember that we were talking about sort of two stages, stage A and stage B. They are asymptomatic, but they have risk factors, right? And there is evidence to say that possibly ACE inhibitors can have a benefit in these two stages, right? Especially in stage B. Especially in stage B, they have some structural change, say a previous MI and a bit of dilated heart, right? Little bit of left ventricular hypertrophy changes in the left ventricle. Some valvular problems. In these sort of patients, they are asymptomatic, but actually ACE inhibitors might have a role. And so probably as well angiotensin receptor blockers. And they're trying some of these newer drugs also in these asymptomatic stages, but the results are not out yet. So you're looking at ACE inhibitors can be useful in these early stages where they don't have any symptoms. Right? So 3 ACE inhibitors have a role in managing asymptomatic heart failure is true. Right. Spironolactone does not have an effect on mortality is absolutely false. All of these first line drugs, ACE inhibitor, ARNI, beta blocker, MRA, dapagliflozin, empagliflozin, all of these have mortality benefit in HFrEF, heart failure with reduced ejection fraction. So, right, I was exactly coming to this question that Sasindra is asking. So what about angiotensin receptor blockers? So you have to understand they are no longer recommended as first line, but they do have mortality benefit to a certain degree, right? Certain drugs, not all the angiotensin receptor blockers, certain drugs, right, like candesartan, have a mortality benefit, Sasindra, but probably not as much as the ACE inhibitor effect. ඒකයි ඒවා පොඩක් අයින් වෙලා තියෙන්නේ උතනින් කතන්දරේ. තේරුණාද? So they are only recommended now if the patient cannot tolerate ACE inhibitors and an ARNI is not available. But they still do have a mortality benefit, right? හොඳම නෑ, but there is some level of mortality benefit. Is that clear?
Yes, sir.
Okay, good. Right, so where are we? Right, now then somebody was asking about, so what about ivabradine? So there are some other medications that we sometimes use in heart failure. Right, so here, they come here. So first line medication is the 5 drugs, right? The 5 drugs here. ඒකේ මේ diuretic එකට mortality benefit එකක් නැහැ, but I told you the problem there. Then the second line therapies, would you try to do a device therapy if they meet this very specific criteria of ejection fraction and QRS, the width of the QRS complex. patients who are not suitable for devices and fail your first line treatment can go for second line medical management. May group මෙතන මැද තියෙන කට්ටිය. So second line medical management is ivermectin. So ivermectin has a mortality benefit, right? It slows down the sinus node, right? So like a beta blocker එකක් වගේ, it slows down the sinus node. It is only recommended if the patient is on maximum doses of beta blockers already. Right? So patient should be on maximum doses of beta blockers. Or beta blockers are contraindicated. One of these things you have to start ivermectin. Either they should be on maximum doses of beta blockers, or there's some contraindication to the beta blocker. Right? Ivermectin slows down the sinus node. Ivermectin is contraindicated if they have AF, right? Absolutely contraindicated if the patient has atrial fibrillation. ඒකත් MCQ එකට අහන්න පුළුවන් දෙයක්. Right? But it has a mortality benefit. In HFrEF has a mortality benefit. Right. Then there's another drug which is a combination of a nitrate and a hydrolazine. Again, second line medical therapies. මේ මැද group එක ගැන අපි මේ කතා කරන්නේ. This group in the middle. Second line medical therapies. That's a combination of a nitrate and hydrolazine. It's sort of a vasodilatory effect. It has a sort of vasodilatory effect. ඒක ගැන මොකද අපි කියන්නේ? Again has a mortality benefit, but it is not commonly used. Right? Not commonly used. ඒක mainly Caribbean, African American populations වල තමයි it is shown to have a mortality benefit. We rarely use it. Right. Right. Then another question was, what about digoxin? Digoxin again is a good second line medical therapy, but it does not, underline the word, does not have a proven mortality benefit. Digoxin වලට. Right? Okay, this is very important. Heart failure, if there is MCQ, they'll ask about drugs with a mortality benefit. Digoxin does not have a mortality benefit. What it does is, it reduces hospitalizations due to heart failure. That is what it does. Reduces hospitalizations due to heart failure, but does not reduce the mortality. Does not reduce the mortality. So there is no mortality benefit. But it does reduce the number of times a patient comes to hospital with exacerbation. And don't ask me why. These are just observations from clinical trials. They don't always have a good mechanistic basis or a pathophysiological basis. Right? Right. So somebody asked the question, okay, what about ivermectin? What about nitrates and digoxin? Right? So those are all second line medical therapies. If the patient cannot have any devices, this is what we recommend. Ivermectin and nitrate hydrolazine combination have a mortality benefit. Digoxin does not. Right. So fifth MCQ is wrong. I told you ivermectin is contraindicated if they have atrial fibrillation. Right. Any questions on this? So this is a very important thing. So this has changed in 2022. Right. This was very different before. Right. So main differences are spironolactone has come up and SGLT2 inhibitors have been included. Right. And ARNI also has come up as a first line drug. Somebody asked about, Mahen has asked, do SGLT2 inhibitors, do you give them even in patients who don't have diabetes? So yes, Mahen, these guidelines now recommend, even if you don't have diabetes, but just have heart failure, to use the SGLT2 inhibitors. Yeah. And that's creeping into practice, right? So, it's creeping. People are using SGLT2 inhibitors. තාම UK වල නම් ගොඩක් අය diabetes තියෙන patient ලට තමයි මේක දෙන්නේ. But in these guidelines, there is no restriction. You can start them even in non-diabetics. Right? In America, they do it quite a lot. Hari. Okay, good. Excellent. Hari. Now, this one is a best response MCQ. I'm not doing it exactly the order of the paper. I'm just doing it where it fits. Right? So, patient has some symptoms, but is asymptomatic now. But the patient has symptoms, right? So there's a reduced ejection fraction, right? and currently on aspirin and simvastatin. So what would be the most appropriate? Remember, you have to start drugs which have a mortality benefit, right? You have to start drugs which have mortality benefit. At the moment, you don't need to put a diuretic in because there are no symptoms. But obviously, if the patient develops symptoms, you have to put a diuretic in, right? So here from this, the best answer is you have to select drugs which have a mortality benefit in heart failure reduced ejection fraction. So from this, ACE inhibitor, beta blocker would be the best answer, right? Digoxin furosemide doesn't make sense. Spironolactone, possibly, but again, ACE inhibitor, beta blocker is the best answer here. Yeah. Furosemide plus G, Anitya Bharati, right? And no other medication needed. The patient has been symptomatic at some time and there is a reduced ejection fraction, right? So ACE inhibitor anyway would be required in this sort of patient, right? And the patient has had symptoms. So this is actually stage C, but currently asymptomatic patient, right? Stage B is different. They have had no symptoms at all, but they have structural changes, right? So any questions about these questions? Monoid prashnati, you know. Right. Again, this MCQ, which is best response MCQ 2, what do you think the answer is here? So, on good therapies, bisoprolol, ramipril, furosemide, spironolactone, right? These drug doses can't be increased further because the patient has developed hypotension when that has been tried, right? And a long QRS interval, right? Ejection fraction of less than 35, neither. So, what should you do? Make a matakai, neither. And there is sinus rhythm, but sinus rhythm. Ejection fraction is less than 35 and the QRS is long, right? So here, best treatment option is cardiac resynchronization therapy, right? It's based on this algorithm. Right. Any questions from those two things? Ramai? Prashna ahanna නැත්නම් තියෙනවා නම් අහන්න please. Either mic or text. Hasni, yes.
Sir, in the first best response question, sir, the patient is asymptomatic, we can't use furosemide, right? If not,
you can't. Never. It's not needed. So you watch. You have to monitor these patients very carefully for symptoms. If they develop symptoms, you start them on a diuretic. Yes.
Okay.
Yeah.
Okay, thank you.
Hi. Udani halatiyana. Right. So ARB has a mortality benefit, but not as good as ACE inhibitors, probably. Yeah. ANI has a mortality benefit. MRA, yes. All of these have a mortality benefit to that. Yes. Furosemide has no proven mortality benefit because of trial problems. Digoxin doesn't have a mortality benefit. Almost everything else has, right? So that you need. That is easier way to remember it. Right, good. So let's move on to question number 4. The make it Godak we have discussed already. So let's go through this one. Digoxin therapy improves quality of life and reduces hospital admissions when added on to existing. So that's right. That is exactly right of the trial finding. So reduces hospital admission and actually improves quality of life as well. But doesn't have a mortality benefit. Right. And the trial, if you're interested, is called the RAILS, DIG. I can't, yeah. Right. So many trials in my head. Beta blockers are contraindicated in patients who have a history of COPD. Now, this is a bit of a tricky statement. On second thought, I think that I would delete this from this MCQ and give you a different one. So just forget about it. The only thing is, don't worry, all so beta blockers are not absolutely contraindicated in COPD or even for that matter in asthma because most of these are cardio-selective. We start them during the hospital admission and sort of observe how they do with it sometimes, right? So a statement is not very good because it's slightly controversial. But remember, practically, sometimes we do use beta blockers in patients with lung airway problems, but under strict observation. Right? Because they are cardio-selective. ඔතන තව MCQ point එකක් තියෙනවා මේක මතක තියාගන්න. We don't usually start, important word, don't start beta blockers for the first time when they have acute heart failure. Right? When they present with acute heart failure, we don't start beta blockers for the first time. Right? එකපාරට පටන් ගන්නෙ නැහැ. Right? එකපාරට පටන් ගන්නෙ නැහැ. What we do is we right. So what we do is we don't start new medication in these people. Beta blockers, we wait for them to stabilize and usually put it on discharge. The evidence is less clear whether you should stop the beta blockers in a patient who is already on them. Right? That is less clear. සමහර අය නවත්තනවා, සමහර අය නවත්තන්නේ නැහැ. හරි ඒක ඔගොල්ලෝගෙන් අහන්නේ. But it's very clear that you should not start beta blockers in acute heart failure while they are still in acute heart failure. It actually increases the mortality if you do that. You wait for them to stabilize and on discharge you start the drug. Okay. Right. Nipun has asked, so in the first state, no, Nipun, in any patient with heart failure, digoxin has the same effect, not only in people with AF. Yeah. Right. 3. Routine.
acute heart failure එකේ AC inhibitors පටන් ගන්න පුළුවන් සර්?
පුළුවන්. ඒවා පටන් ගන්න blood pressure එක චුට්ටක් බලලා පටන් ගන්න ඒවා. හරි? ඒවා ප්‍රශ්නය නෑ. Beta blockers is the problem. You don't start them in the acute stage. Yeah. Tisura.
Thank you, sir.
Sir, the BNF gives asthma as a contraindication for beta blockers.
Oh, make a cardio selective nisa. Some people do give it. That's why I said it's a bit of a controversial thing. Sometimes you think that the benefit is more than the risk. And remember, sometimes asthma keyword, it's actually heart failure that they have, right? So you have to be very, very careful. So it's a bit of a decision sometimes, right? Careful decision.
Excuse me, sir.
Oh, that. Yes.
Sir, if there is a known patient with atrial fibrillation and presence with heart failure, even that moment, don't we start beta blockers? Even the patient has chronic season, non-patient with atrial fibrillation, and now presenting with heart failure.
Yeah.
Do we not start beta blockers in that?
That's a different story. That is a different story. Then you have to start beta your rate control. Here, this is say any patient with acute heart failure without AF or any other indication for the beta blocker, you should start it acutely. But if you have AF, obviously you have to give it. Otherwise, they will die of the AF or it is have complications of the AF. Yeah.
And sir, between digoxin and beta blockers, what is preferred in that kind of situation?
Loku prasnyan. So, it all depends on the blood pressure. And also, if you are worried about beta blockers, you can give digoxin. It's not a problem. Especially if the blood pressure is low, I would sort of give digoxin. Yeah.
Okay, sir. Thank you very much.
Yeah. But these are again more sort of therapeutic, sort of higher level decisions. Yeah. But you can use beta blockers to control the rate. If you're really worried that it's going to affect the heart failure, then you sort of put digoxin in. That's fine. Yeah. Right. So we're talking about anticoagulation with warfarin. So there is no indication for routine anticoagulation in heart failure. Absolutely no indication. Of course, if the patient has AF, yes. So AF and heart failure, probably yes, anticoagulation. And also some people with heart failure can get a clot inside the ventricle, for example. So they might have a intramural clot. You can anticoagulate, but no routine anticoagulation. There was a theory those days when the ejection fraction is about 10%, you start warfarin. There is nothing like that, right? You have to have a strong indication for anticoagulation. For example, AF and heart failure. For example, intraventricular thrombus and heart failure. You have to have some sort of clear-cut indication like that. Shamalka අහලා තියෙනවා yeah, so Shamalka, yes, at least two first-line drugs you have to start, preferably. Some people give more. Some people go all of those first-line drugs at once. But most of the time, then we currently we put AC inhibitor, beta blocker, and spironolactone. We usually put 3 or at least 2 as the start, yeah, and then increase the doses as required. Right. Then we were talking a lot about mortality benefit, right? Mortality benefit, and actually, ventricular arrhythmias are the commonest cause of death in patients with heart failure, right? That is one of the commonest causes of death, right? Others are MI wage දේවල්. But remember, there is no place, මේකත් MCQ වලට අහන්න පුළුවන් එකක්, there is no place for prophylactic antiarrhythmic drugs in heart failure. No place for prophylactic antiarrhythmic drugs. No place. Right. But we know that ventricular arrhythmias are the commonest cause of death. So, but clinical trials have shown there is no benefit in giving a prophylactic antiarrhythmic. Right. Last one is that we talked about the CRT ICDs. The influence can have an influence effect on mortality. So they have a mortality benefit actually, right? But the word influence එතන එච්චරම හොඳ නැහැ ඉංග්‍රීසි මම හිතන්නේ again වෛතික පාස් පේපර් එකක් වෙන්න ඇති. So they do influence mortality. They have a mortality benefit, right? They have a mortality benefit. And you give them, but only in very specific situations. කියන එක මතක තියාගන්න. හැමෝටම ඕවා ගිහිල්ලා ගහන්නේ නැහැ. Remember, very specific situations. They have to be on their medical management, right? And then you consider this if they meet the criteria, if they meet the ejection fraction criteria, if they meet the QRS with criteria, then there is a place and there is a mortality benefit of CRT, ICD, ඔක්කොම mortality benefit. ICD දාන්නෙත් if they have ventricular arrhythmias, history of ventricular tachycardia වගේ දේවල් තියෙනවා නම් ICD එකක් දාන්න පුළුවන්. Right. Any questions about these ones? මොනවද ප්‍රශ්න තියෙනවද ළමයි?
So is it the atrial fibrillation or ventricular arrhythmias common cause of arrhythmia?
Ventricular. Common cause of arrhythmia නෙවෙයි මෙතන කියන්නේ common cause of death. AF doesn't usually cause death, right? But ventricular arrhythmias can cause death. Yeah.
Thank you.
Yeah. පොඩ්ඩයි නේද රෙහානිගේ ප්‍රශ්නට උත්තර දෙන්න. Is there a place for CCB in So no, there is no place. Actually, calcium channel blocker use can be detrimental in heart failure, right? So we don't prefer it. If you want to use a calcium channel blocker for some other reason, amlodipine is probably the only one that you can use, right? Just a sort of a neutral effect. But remember, amlodipine will ankle edema will එක එක ජල්බරි වෙනවා. But it has a sort of a neutral effect on heart failure, right? Right. Okay.
Excuse me, sir.
Oh, Ken.
So in the fourth statement, in the fourth question, sir, what is meant by advanced heart failure and common cause?
Oh, advanced heart failure කියන්නේ stage D වගේ or C to D වගේ. Yeah. And especially when the ejection fraction is low කියන එක තමයි 35% ඒ වගේ ඒවට.
Okay. Still the commonest cause of death is ventricular arrhythmia?
Yes, still. Overall, yes. Yes.
Okay.
So in advanced heart failure patients, when we have to walk and exercise, it will add on the cardiac demand. So when they are having to bed rest, don't we need to prescribe them anticoagulants?
That is a different thing. So bed rest කියන්නේ මෙහෙමයි. You don't encourage bed rest in patients with heart failure. Obviously, you want them to move about. up to their level of tolerance. That is how you explain that, right? So they can't be in bed all the time. In hospital, that is a different story. Then we obviously give them a prophylactic dose of anticoagulation, right? Not a treatment dose of antibiotic. That is just a short duration, right? If they are immobile, you give them a short duration of prophylactic antibiotic, which is different from what I was implying in the other in the statement. Yeah.
Thank you, sir.
Right.